Thank you for joining our Dr. Brown's Medical Educational Webinar Series provided by the Medical Division of Handi-Craft Company. Today I am honored to present Sue Ludwig. Sue is passionate about improving the quality of life for infants who begin the journey early. She is president and founder of the National Association of Neonatal Therapists, Nant, an organization that supports therapists working with babies and families in the neonatal intensive care unit. She is also the co-founder of Infant-Driven Feeding, created to advance oral feeding practice on a global level. Ms. Ludwig has been an occupational therapist at the University of Cincinnati Medical Center for over 20 years and is driven to improve the culture of healthcare, armed with decades of experience speaking for those who cannot speak for themselves. Sue has received the Laura Edmonds Lectureship Award from UMass Memorial Medical Center and was awarded for her individual contribution on maternal and child health in the National Perinatal Association. Sue is a sought-after speaker, consultant, writer, and educator, a publisher, author, and poet. She resides in Cincinnati, Ohio with her husband and 2 young children. Sue will be presenting Oral Feeding and the NICU Parent, 5 practical ways to empower and educate. Thank you, Sue.
Thanks, Sandy, and thanks everyone for being here. And Sandy, can you hear me okay before you disappear?
We can hear you great.
Okay, great. So thanks everyone for taking the time to be with us today, and thanks to Steve and Sandy and Dr. Brown's Medical for inviting me to speak on what is one of my favorite topics, as you well know, neonatal feeding. So I'm going to try to keep pretty much to my time frame here because I want to be able to answer some questions if we have time. So quickly, the objectives, which you can read on your screen, are just really I want to help you identify the primary role of us as professional caregivers in neonatal feeding practice. I want you to take home 3 practical teaching points that do empower parents in that transition to oral feeding, and define 2 pre-feeding activities in which parents can participate from admission forward. My disclosures are that I'm like Sandy said in my bio, I'm the co-founder of Infant-Driven Feeding and the president of Nant. And the reason I bring those up is because I've been asked to provide some resources for you. And so when I talk about those resources at the end, they're going to involve these organizations. And so I just wanted to make that clear up front. So as you know, oral feeding is a huge topic, and many of you have heard me speak about feeding for hours on end. So what exactly are we going to cover in this time frame? But as the title and objectives really illustrate, we're going to focus on the family, on how to educate and empower NICU parents and families about oral feeding, which in the end is the most important thing that we can do for infants. And just to note that throughout this presentation, I'm going to use the phrase oral feeding because the ways in which we teach and empower parents do not necessarily always need to be segregated into breast or bottle feeding. Of course, there are specific points for each method of feeding, but overall, I think we need to do a better job and more consistent job of addressing the feeding as an actual teaching point first. If we don't all start from the same place of knowledge and understanding, we're going to continue to confuse families with every change and shift and every caregiver. So when I say oral feeding throughout the presentation, I mean breast and bottle feeding, unless otherwise noted. So before we begin talking about the 5 practical ways to empower parents, I want to make a few things clear so that we're all starting off on the same foot. I'm going to make some underlying assumptions about just overall feeding practice and culture. So your unit or practice may not be 100% there regarding these assumptions, and that's totally fine. We are all in progress. It's just a continuum. None of us are in a perfect utopia, but each of these assumptions could be kind of a talk unto itself. So let me just run through them briefly for the sake of clarity. The old or traditional way of progressing infants from tube to oral feeding, meaning volume-driven practice, once a day, twice a day, every other feeding, that kind of practice. That way of practicing is really over, meaning that it is not supported by evidence or potentially better practices or anything that we can reliably count upon. Most of the country has been making a concerted effort, really for years, to move toward a more cue-based, infant-driven, co-regulated style of feeding. But it doesn't mean that they've all been successful, because it's a big thing. I spoke actually recently, about a week ago, with a nurse manager who stated that they've really been trying to change the feeding practice for literally 20 years. So she had footage and documentation and in-services from 20 years ago where they were talking about many of these same things that are still not consistently done in their NICU. So I know that many of you can identify with that, right? And for culture and practice to be better, all staff really need to be educated in better evidence-based practices, or your efforts to support and empower parents will be inconsistent at best. This is the really frustrating part to those of you who have been attempting to do the right thing for years. That inconsistency is just evident. So just ask any NICU parent how many different ways they were taught to feed their baby by NICU staff. And well-meaning staff, we're always well-meaning, but we're inconsistent. So we have done them a disservice overall by not being on the same page and making feeding a well-thought-out practice. So the little bullet that says feeding tools do not equal feeding practice, I want to talk about this before we get started because there are many tools out there by many authors, and a lot of them have to do with feeding readiness and measuring feeding skill, feeding quality, taking you through the process of feeding, including my own. But as mine and Kara Ann Weitzman's, but as every author of every tool will tell you, a tool is only as good as the practice and culture it's placed into. So tools do not change culture, which is the most insidious part of this change. But people change culture, and education changes people. So the tools are great, but we will fail to bring the results that we want to our parents and to the infants in our care if those tools aren't embedded in sound education and a deep understanding of neonatal feeding. So when we do use tools, and they are a very valuable piece of that practice, we must include the parents in them as well. So they have to be able to use and understand them as part of a greater feeding practice. As many of you know who are listening, oral feeding is a complex sensory motor activity that requires an educated, observant caregiver to really promote lifelong successful feeding and functional eating. So we all must be well educated in feeding to really adequately and accurately teach the families that are in our NICUs every day. Feeding is also a psychological, social, and emotional experience. So those of you who are parents out there, you know that feeding your child is an inherent part of feeling like a parent. And as a child, being fed is a basic human need that is most often accomplished by your parent. And that successful feeding is not determined by volume alone. And of course, you guys know this, but continuing to have a volume-driven versus quality-driven practice is a silent yet detrimental culture for infants, family, and staff. So I'll be happy to answer questions about that later, but I just want to make sure that we all are kind of understanding these assumptions before I begin to talk about anything else. And really the most important thing for us to remember is that there is no one magic bullet for eliminating neonatal and pediatric feeding problems. The issues that we see, whether in the NICU or in follow-up or in long-term follow-up, are the result of a complex mixture of known and unknown factors. So there is no one solution. So I just want to say that because not to discourage anyone, but to really let go of the thought that this is a quick answer, that there is an easy solution, as much for our administrators as anybody. That changing feeding practice is never easy, it's just that it's worth it. When we talk about the primary role of the professional caregiver in neonatal feeding, it is really this, that we need to make our focus primarily connecting the infant and the family. Really, the pictures here depict, both the NICU but beyond, because we too often in the NICU think feeding ends when the infant has kind of gotten out the door of the NICU, maybe taking all of their feeds by mouth. And we're sort of pat ourselves at the back and think, we've done a good job and this infant is eating. But we don't always know or even find out how well that infant transitions into other stages of feeding and if they are successful on all levels, both functionally, psychologically, emotionally, and functionally with feeding. So it doesn't really matter, in essence, if we as staff can feed the baby. What matters is if we've helped the family understand how to best feed and connect with their infant. It does matter as professionals if we can assess oral feeding, if we can provide input regarding feeding practice and understand deeply what we're doing when we do feed the baby personally, but also when we educate the parent. We want to be accurate when we're educating the parent. But the primary goal must be to educate and connect the infant and family in the process of oral feeding. So if we don't understand, everything that you do in your feeding practice should stem from that primary role of connecting the infant to their family for lifelong successful feeding. So I'm going to talk about each one of these things. So this slide just summarizes the 5 practical ways we're going to talk about. Just starting their feeding relationship at admission, developing a simple new mindset, educating families about neonatal feeding, supporting a new feeding culture, and identifying a model of consistent practice. So we're going to start with, obviously, number 1. So I want to kind of reframe how we think about feeding, that we want to start the feeding relationship and the education related to it at admission. And that might seem strange when you're thinking of, well, what if I'm admitting a 24, 25-weeker? What can I be, feeding doesn't happen until way later, right? But I want us to reframe that, because the infant that is developing from that point on is going to, the way we care for them and the way that infant develops is going to contribute to the success of feeding later on. And how involved that parent is from the beginning is going to be a huge part of that. So some of the things that we want to do is really get the family in the bed, with the infant and holding the infant and skin to skin early and often. Because what happens when we do that, besides all of the psychological benefits and bonding that happens with the parent and infant when we encourage that, that parent also begins to learn the infant's cues from early on. So sometimes we act as if feeding cues are suddenly a new thing, but really we should be teaching parents how to read those cues from admission. Because even though they're not necessarily feeding cues at that point, they're behavioral cues. And when the sooner the parent can begin to understand how premature infants or sick infants communicate, the more they're going to understand them from the beginning, and certainly by the time we get to oral feeding. And so feeding cues, I want you to think of them as just on a continuum of education about cues for the infant and the parent. It never really ends, right? For our whole lifespan, we give behavioral cues, whether we know it or not, or admit them or not. For teenagers, they might be eye rolling and audibly sighing, right? There are cues throughout the lifespan. And for the infant, we really want to teach the parent, what is it about premature infants and how they communicate that we can start to read and respond to early on. And then certainly, even when they're just holding the tube for a gavage feeding like this dad in the picture, or when doing skin to skin, where the parents can begin to understand how their infants respond to being fed even before the process of oral feeding begins. They can also provide this human nurturing experience every time during feeding, way before we get to oral feeding. So this is not just vital for bonding and attachment, but for establishing feeding as this nurturing social event from admission forward. So even when the baby's on a pump for feeds, even when they're getting gavage fed, can we provide some human touch with all of those experiences, ideally through the family, and if family is not present, through us as caregivers. So, I just love this example, just to bring it kind of home to the bedside, is that it is not normal ever, from a biological or evolutionary standpoint, for an infant to eat or be fed in isolation, to be left in a box and to be walked away from and then be receiving nutrition. And yet this is what we do for days, weeks, and sometimes months in the NICU. Infants are fed via tube, IV fluids, etc., with very little human contact at times. And when I say human contact, it's not that we're not caring for the infant in a medical way, in a procedural way. We're doing our job at a very high level. But are we providing any actual human interaction and human touch that is paired with those feeding experiences? So sometimes we do. Sometimes we do provide containment. We hold the infant, or the parent is there and can do skin to skin, and that would be the ideal. But sometimes because we're busy and that takes time, we might leave a parent sitting at the bedside with their arms just strikingly empty while their infant is being fed just inches away from them inside the incubator. So I think we just need to move all of this back and think of how we can help them from the very, very beginning with that development. So as many times as that parent is able, whenever he or she is in the unit, how can they provide some human touch during feeding? Containment at least, skin to skin ideally, with a pacifier if they're being fed and if they're interested. So that one simple step, if made part of unit culture and parent education, could change the infant's experience of feeding dramatically. So just 4 very concrete things that parents can do to help prepare their infant for oral feeding at whatever age they are is, again, offering that human versus procedural touch with as many feeding opportunities as possible from admission forward, offering non-nutritive sucking with an age-appropriate pacifier when the infant will accept it, whenever possible, to be paired with feeding. Skin to skin early and often. And I put that in a different color because it is the most important, and it costs zero money, by the way, right, to provide skin to skin. And it is an extremely powerful neurodevelopmental tool, and one that sometimes we bypass because we don't have time to get a chair. We don't have the space to get a chair. The administration doesn't understand why maybe that should be a comfortable chair that's particular to skin to skin. So there are a lot of barriers, but this is an easy thing to provide that is extremely powerful. And then they can also just be, we can, as caregivers of the parent, just be dipping that pacifier in breast milk if available, or formula with their tube feedings if there are no medical contraindications. So again, looking at these very concrete ways to consistently try to make this feeding experience positive from an early age. These are all things that we can empower the parents to do at the bedside. The second thing that I want you to do to really empower parents is to develop a new mindset. And some of you already do this, but in a lot of units that we see, the mindset is still that the professional comes first and the parent is second. And what I mean by that is that the model should be switched, where the parent and infant interaction comes first in the feeding experience. And as caregivers, that we are the observer, we provide professional guidance and education. For example, in the old model, the staff, whether it was nursing or therapists, we would provide the first oral feeding as a way to assess the infant's safety and competence, with feeding and swallowing. And that would make us, in the best case scenario, our perspective was that we were safeguarding the infant and making sure they could, swallow safely, etc., before putting the parent in the position of a potentially, scary event during that first feeding. But in the worst case scenario, we were protecting our turf as professionals. We were saying, no, I must do this first to make sure that the infant is safe, but a lot of times that was only about turf and territory. And so we want to switch our mindset to really putting the infant and the parents first. So for example, if the mother is a breastfeeder, then the first oral feeding should be at the breast, not by a bottle. And obviously we need the parent present to do that. So how are we preparing that mother all along to be ready for those moments, to be already doing skin to skin, already, really doing kind of pre-breastfeeding activity before we get to the point where it's about oral feeding? And I don't want to forget the bottle feeders either. So if the mother or the parents are bottle feeding the infant, they should also be notified and be made aware of when is around the time we're going to try to provide the first oral feeding, because they should be the ones to do it. They should at least be offered the opportunity, because they have already missed so many first experiences for their infant, and this should not be one of them. It's too important. Often and I have never had anything, and believe me, I've done my fair share of taking the first feeding in my career, and that's why it bothers me so much, and why I want to try to help other people not do that anymore. And really that, put your fears, at rest, that, nothing has ever happened to an infant when they've been in a parent's lap doing that first feeding and I'm sitting there teaching them, or a nurse is, or anyone who's carefully sitting there observing, nothing any worse than what would have happened if I had the infant or the nurse had the infant has occurred, because we're going to intervene if there's something that needs to be done. And instead, what we want to do is empower the parent that they were important enough in this process to be there for that first experience and to imprint that with their infant. And sometimes we get in that ICU mentality and we think, oh, well, we can't wait on the parents. Well, that's a true statement. We can't wait 2 weeks for them to show up and hold oral feeding, if they're never showing up. But sometimes we act like we couldn't wait 12 hours. Is there a difference between providing that first oral feeding? Does it have to happen at midnight? Or can it simply happen at noon the next day when the parent is available? So I think just changing our mentality to really focus on that first experience and having not only the first, but for sure the first experience with their infant. When we sit with them and walk through it together, we will be able to teach them right from the onset everything that they're going to need to know. Some of which is what I want to talk about here. So the third thing that we can do to really empower and educate parents is educate them in neonatal feeding. And the reason I'm putting this in here, because it seems like obvious, right? But a lot of times we forget the environment that we're actually in and that we think that this is normal. So this picture here is of a baby in a NICU who is showing some feeding readiness cues, right? So he's alert. He's got, good muscle tone. He's rooting on his own hand. He's eyeballing his pacifier. Just kidding. But he's in a place where he looks like he is showing some readiness cues. But if you don't know what neonates look like when they're showing feeding readiness cues, if you've only ever had full-term babies and breastfed or bottle-fed full-term babies, you might think that they have to cry first or act very fussy before they're ready to eat. When in the preterm population, some of these cues are going to be much more subtle, right? And so we want to teach them the difference, and that's just one tiny example. So I wanted to just talk about the way that I think about teaching parents when we're in the moment about actually neonatal feeding, and just a kind of a template of how you can think about it. And many of you might do the same thing, or you do something different that works for you. That's totally fine. But this is something I feel works well to help parents understand what they're doing in the moment. For example, breast or bottle feeding, I want them to understand, and again, if they've been doing this all along, if they've been holding their infant all along, this is something that shouldn't be new. But I want to teach them to feel their infant breathing first. So whether they're watching their little neck and see them breathing and see that musculature, changing with breathing, or whether they're feeling it on their infant's back, we want to get them used to feeling the rhythm of their breathing before we're doing any feeding. And then we want to teach them that for preterm infants, right, there's going to be a suck, swallow, breathe pattern that is fairly unique to a preterm infant, meaning that preterm infants are going to suck and swallow in bursts, right, followed by grouping their breaths together. So for the most part, a preterm infant is going to have a series of sucks and swallows, followed by, right, panting in a panting-like motion, right, for their breathing. So they're going to group together in that burst pause pattern, their sucks and swallows, and then their breathing. And if we teach the parents about recognizing that pattern, it will inform every other thing that comes out of that. So if they don't understand the pattern, they're not going to understand when the pattern's been interrupted by something, by poor swallowing, by getting too much fluid, by apnea. So first they have to understand the pattern, and then they're going to understand when that pattern has been interrupted. So what I might do is literally while they're doing that first feeding, I'm going to maybe have my hand on the infant's back as well, or if I can see them breathing, if you have chronic lung disease, you're going to be able to see that, right? But I'm going to help narrate what is happening so that the parent can begin to recognize the pattern. So I might be saying something like, okay, now now baby Abby, now she's, sucking and swallowing, and we can tell that by the following things that we're seeing. Okay, now she's pausing, and okay, now she's breathing. Can you feel her breathing? Right? Okay, now she's going back to sucking and swallowing. So if they just get that simple rhythm that sometimes looks like long bursts of sucks and swallows, sometimes only 2 or 3 in a row, because these babies are not consistent yet. They are not mature yet, and their patterns are going to change all the time. So what we want to teach the parent is not the baby's going to suck 5 times and then we pace them. That's an old way of thinking. What we want to do is watch the infant all the time. Feel the infant breathing, watch how they're progressing, and then only intervene when necessary. So intervening meaning that maybe when the infant does pause to breathe, and then they pause, and then you pause, and you're waiting for the breath, and they're truly apneic for a number of reasons. Maybe they had, maybe they choked, maybe they got too much volume, maybe they're just, apneic because premature babies have apnea. So there are a lot of reasons that they could be apneic. But if the parent recognizes that when the baby pauses in sucking and swallowing that they should breathe, and then those breaths do not happen, then they know that's a point at which we need to do something. And then we can teach them from there what might be appropriate in that moment, which looks different depending on whatever happened. Is it the swallow? Is it whatever's happening? Do they have milk? Are they having milk coming out the front of their mouth, anterior liquid loss? That might be one. Then we do one thing versus if they're just apneic. So then we know where to teach them from. So just teaching that pattern is going to be a huge place of understanding. And parents really get this very quickly because they're feeling it and they're seeing it. It's not abstract knowledge. They're seeing it happen. Once they understand that, it's really easy to go from there. And then also teaching them before we're actually having the baby eat. Obviously, we're going to teach them about feeding readiness cues. We're going to teach them what they look like in a preterm infant. But while feeding, we're going to teach them what feeding quality looks like. So when an infant has a quality feeding, what is that? What are the characteristics of that? Is it smooth, coordinated movement? Is it that they're pausing to take their own breaths, or that they're responding to pacing if we do have to do that? So what does it look like to have a quality feeding? And you'll want to describe what that looks like, because in the past we know what we've used to describe as quality feeding. So this whole idea of educating them in neonatal feeding is very important, because I think too often we assume that people know what we know. We've done this for a long time, everyone, so you know a lot in your head. It's communicating that very simply to the parent and giving them a place to start, and then you can teach them from there if in fact they need to intervene. And so many of their own gut reactions are already correct, because especially when they've been able to hold and interact with their baby for weeks before now. So letting them have a little room and a little space to honor what they already know about their infant before kind of jumping in and pre-deciding that for them. So helping them with that co-regulation piece is a huge part of the puzzle. So start simple, start with patterns that they can recognize, what they're seeing in front of them, and go from there. We also want to support a new feeding culture, right? So we want to help them understand that there is an old culture and there is a new culture. And if you work in a unit where it is all new culture and there is not a shred of the old culture left, then I am so happy for you, and you are very unique on the planet, and congratulations. If there is zero old culture to eradicate, then that is fantastic. But for a lot of units, even if you work in that kind of unit where everything is an improved culture, which I'll describe in a minute, it doesn't always carry over to the systems that exist outside the NICU. So when the therapist comes for early intervention, they may not understand. They're used to the old culture, or they don't know any culture that has happened in the NICU, or the pediatrician doesn't understand where they've come from. It goes on and on and on, and these parents are left to fight all of these battles on their own once they get outside the NICU. So we want to really help them recognize what are pieces of that old culture, even if they see it outside the NICU, and where should we help them go and give them the confidence to speak up and advocate in those situations. So, part of that culture is educating them in the importance of quality over quantity. So whether you've worked in the NICU for 3 years or 30 years, you've likely been raised in a volume-driven culture, like I was. So meaning that we believed through the culture that our primary goal was to make the bottle empty. Okay, so it really didn't matter how it happened. It didn't matter how much milk was on the washcloth at the end of the feeding and how much liquid loss there was. It didn't really matter if the infant had a 15 ml emesis. I mean, we wrote it down, Don't, I get that. But it didn't affect the fact that they took the whole feeding, because that was the definition of success, which, by the way, left no room for breastfeeding, since breasts do not come standard with volumetric markings up to 60 mLs on the side. So that culture which we lived in, but therefore didn't examine, led us all to create ways to get volume in the infant rather than helping her to eat, which are two very different approaches. It also made us throw each other under the bus as caregivers. So just as one tiny example, as a new therapist in the NICU, I very much felt like, from a cultural standpoint, nobody told me this was not in a policy, nobody came and told me it outright, but I felt like if I was worth my weight as a therapist, I better get, now this was 20 or whatever years ago, mind you, but the culture told me that as a therapist, I better get the infant to take more volume than the nurses did, or why was I even valuable? What did I even know about anything about feeding babies if I couldn't get the baby to take more volume than the nursing staff had? And the nursing staff felt like that, right? There was a competition, and not just therapists and nurses by any means. It was nurse to nurse, right? So the best nurse in the nurse that got the baby to take the most was the best feeder. She could feed a rock. She got anybody to eat. Give her the baby that doesn't eat at all, and she will make that baby eat, right? Now, that's not taking away any of our skills. We do have skills when we have fed babies for that long. We do understand a lot about neonatal feeding, but that is very different from making a baby eat and force feeding the last 12 mLs in the baby so that we can make the bottle empty, whether the baby had any active engagement in that or not, which is unsafe and unethical at this point. We know too much to do that anymore. So that culture, we lived in it, we were raised in it. So, culture in and of itself could be an entire other presentation, but here's the news I want to give you today about it, is that it's okay to let it go. You have permission to set aside some of the things that we all thought were the status quo of feeding in the old days, and even currently in many units, and step into a new culture that supports the infant and family and the quality of the feeding experience in the NICU and beyond. It's way past time to let go of this, but I'm giving you permission today to officially set it down and to say, you know what, we didn't always know better. We typically do the best we can with what we know. And when we know better, we do better. So if this is the first time you're ever hearing something like that, then fine. It's not like something to be, it's just like open your mind, let that sink in for a while, and figure out how you can slowly let go of that culture in your unit, and how can you help the people around you to do the same. So there's really no shame in that old way. There were not a lot of resources, and there wasn't a lot of focus on feeding for decades. Okay, so we were just doing what we thought was best at the time. But it is officially time to move on. So what does that have to do with parents? And it has everything to do with parents, because they live in the same place we do, and they learn from hearing us talk. So even me saying, how much did you get in the baby, is a cultural statement instead of how much did the baby eat. So they're watching us. Why else do you think they would kind of hide in the corner and feed their baby for 45 minutes to an hour when they know their infant isn't interested anymore? And it's because we've taught them that if they're a good caregiver, if they're a good parent, they'll get their baby to take the whole bottle, or that they'll breastfeed for X amount of time. That they want their infants to eat as well or better for them than these, quote, strangers who are taking care of them. So your example is a powerful way to educate parents all day long, that quality is what matters and the quantity will follow. So the fifth thing that I want you to use to really help the parents, the last thing, is that I want you to really educate the parents all along about your unit's process for the transition to oral feeding from admission forward. Because what does your unit say as a whole to parents about that process? If you just ask maybe 10 people in your unit to describe how they educate parents about that transition, how many different answers might you get? And is that inconsistency due to the fact that you don't have an actual model or protocol or consistent practice about which to base that education? So I love this quote that we are what we repeatedly do, that excellence then is not an act, but a habit. And that is so true, because if there's nothing to hold on to, if there is no model, there's no protocol, there's no algorithm, there's no practice, it's very difficult to get 100 people in any given NICU to say kind of the same thing to the parent. So it's very unrealistic to expect consistency if there's not something consistent in place. So, I think when Kara Ann and I have taught so many caregivers around the country about feeding, that we've realized that most units, not all, some of you have great protocols and practices in place, but most units do not have a consistent practice protocol model on paper anywhere, on quote paper, right, on the computer, that they can refer to, learn from, or teach about. And this really affects the consistency with which we teach parents and with the language that we use, and to help the parents understand their role and to help the staff understand their role in educating parents. So if there's no model, we just have inconsistent education, inconsistent practice, and then you'll also have inconsistent parent satisfaction, bar none. That will absolutely be the result of your inconsistent practice. And what the real sadness in that is not your parent satisfaction scores, and it's the way the parents leave the NICU for the rest of their life with that infant and try to struggle with what they've been taught. If they leave with this solid foundation, they can be empowered to go out into the community and get resources that are in alignment with what they were taught in the NICU as sound practice. So there are a handful of really great feeding protocols and practices out there. Some units have originated their own, like they've gone and really dug into their own unit and practice and created a whole approach based on their individual unit, and they're fantastic, and they've worked for that unit. There are other ones that are more kind of widely available, and whatever, my point is, whatever you do something. So this is not about which one you do, it's about choosing one and having a consistent practice that's based on evidence and based on the literature in order to give parents a good foundation. So I'm going to talk about one example, which is infant-driven feeding, developed by Kara Ann Weitzman and I and myself, and because obviously it's the one I know the best. So, for example, infant-driven feeding is a neurodevelopmental approach to oral feeding. It does start at admission forward, includes breast and bottle feeding. It does include the infant-driven feeding scales as an assessment and documentation tool. But again, the scales are not a practice. So we have seen over and over people who use the infant-driven feeding scales, but they have zero education in the practice of infant-driven feeding. And so they think they're doing infant-driven feeding practice, but really they're using a tool, which is fine, but it doesn't mean that they understand the greater picture and the deeper education that has to happen for any feeding practice. Every approach that you will see, whether you're using the SOFI, whether you're using the early feeding skills assessment, whether you're using one that your own unit developed, there are lots of great things out there. They all have the same premise, which is that we need to have a neurodevelopmental approach to oral feeding, that this is more complex than meets the eye. And so have a system in place that addresses all of the infants' systems as they develop, and feeding is one part of that system, and how can we better support it. So the goal of all of those systems, all of those protocols and practices is really to lay the foundation for the infant and family for a successful future with feeding, so that we don't want to just look at getting the infant out the door of the NICU, POing 100% of their feedings. We want to get them to be discharged from the NICU with a solid foundation of education, that they are a quality, that they eat with good quality. That they're not just getting we're not getting the volume in. The infant is actually taking it in themselves, 100% of it, and able to sustain their own growth and nutrition in whatever way best works to get their nutrition in for that infant. Whether it's a combination of breastfeeding and tube feeding, whether it's a combination of, breast and bottle, whatever the method is for that individual infant, that we are giving them a solid foundation for the future, and that we've given them skills and language where they can further advocate for that same kind of aligned, comprehensive, holistic view of their child and feeding. So no matter what method you choose, really look at that, having that quality-driven culture at its core. You know, what we do in the NICU matters for ultimate long-term feeding success. So let's just begin with a system that supports that goal, whichever one it is, and a goal that does not end at NICU discharge, but is just the beginning. Sandy had asked me, she said that when they have talked to, NICU caregivers, that one of the main questions they get is, well, okay, I understand these kind of things need to change, but how do you do that? Because I'm one person, or we're 5 people among 100 and 200 staff in a unit. So how do we affect change? And there's always some champions, right? Nurses and therapists usually combined, and physicians often, but it's hard to know how to enact change in that big group of people. So Sandy had asked me to provide some tangible resources about how to go about that kind of practice change, because it's a big thing, for any unit to kind of bite off that kind of practice change. So I'm going to give you the resources I know best, which are infant-driven feeding. So just quickly, 2 resources for you. The one on the left that says Comprehensive Online Education for NICUs was created. This is an online course created by Carrie Ann Weitzman and myself that was created to address the problem we saw most often in NICUs around the country, which is how to educate every single bedside caregiver in the complexities of neonatal oral feeding in an efficient and cost-effective manner. And then how do you ensure that all those staff, all the new staff, have the same access to that education? So this course in particular was developed so that your hospital could actually purchase the course and assign it to all of your NICU staff, in your own hospital education system. So however you go on to take your hospital education, this particular course can be assigned to you as a NICU caregiver. That course is new in 2014, so you may or may not have heard of it. Our website is there, infantdrivenfeeding.com, if you want to learn more about that course or take that course as an individual. Another resource that I added here is just a free ebook, The 7 Risky Mistakes NICUs Make with Oral Feeding Practice Every Day. You can also get that at the same website, just a free resource for you and your unit, especially if this idea of changing culture and practice is new to your unit. It might be just a nice place to start with no financial investment whatsoever. So just a nice resource for you. And then also in looking at topic-specific education related to neonatal feeding, whether it's dysphagia, breastfeeding in the preterm infant, how do you thicken feeds in this population, new research related to feeding. Just wanted you to be able to check out the agenda for the 2015 Nant Conference, as I think there are at least 9 feeding topics represented. So you can just go check out at nantconference.com. You can check out that agenda and see if any of those feeding topics are something that you've been seeking out in the world, because sometimes those are difficult things to find related specifically to the neonate. So just wanted you to have that, and that was in your handout as well. So I tried my best to leave at least 10 minutes for questions. So I am open for business. So anybody that has questions about anything I talked about or anything I didn't, whatever feeding questions you have, I'm hoping I can help.
Sue, thank you so much. We do have some time for some questions, and I'm going to read. The first question is, are there any suggestions for babies who prefer disposable hospital nipples and will latch on to a nipple shield or silicone nipples?
So the question is, what if they prefer the hospital base nipple? Is that what the question is? Okay.
Yes.
So one suggestion, and it doesn't help you with an infant who already prefers it, but one suggestion is starting the exposure to the nipple shield sooner. So obviously, if this is a breastfeeding infant, having them go to breast first before bottle feeding always, and then they will, and having them do that as much as possible is going to decrease that from the nipple shield anyway. So having some protected time where it's only breastfeeding before you start bottle feeding, And then also, if you're going to have parents, whether they bring in their own bottle or you provide a commercial bottle for the infant, something other than the volume feed and nipple, just bringing that in earlier will be better. If they're already, if this is a situation where the infant already prefers, right, because there's a big difference between the taste and everything of a rubber nipple than maybe a silicone nipple that you get from a commercial bottle, right? The taste, the feel, the smell, everything. And so if they won't take the other one, I would say, you know, introducing it in a way that the infant is still it's pleasurable. So whether it's a short amount of time, you know, maybe it's one feeding a day and then slowly adding that particular bottle in more and more. With the breastfeeding, I think it's all about starting that first, just to be clear, and modeling that first, imprinting that first. But if it's in a bottle situation, I would slowly add the other one in, is, you know, one time a day, twice a day, etc., until where the infant's comfortable, until you can kind of help them transition over. But sooner the better, especially if you have an infant that you feel as a therapist or nurse, you feel like they're kind of preemies tend to be picky from a sensory standpoint, and so the earlier we can do that transition, the better. And the same thing would be true if they're at home, kind of adding it in slowly, because you don't want it to affect intake and volume and growth.
Okay, Sue, we have another question. It says, coming from volume-driven standpoints, how do we encourage staff to put baby to breast for our breastfeeding moms? I feel so many of our moms give up so heavily to measure volumes.
Yeah, so that's a big question, because the answer is a lot of things. So part of it is, if the unit's culture isn't going to support that mother, so they might be giving up because they can just feel, see, hear, and understand that the culture of that NICU, whether anyone says this out loud, of course not, but sometimes they do actually, is if the culture still exists where the pressure is on the mother to get the volume in with a bottle, she will quickly give up and say, well, it's just easier to see what they're taking out of a bottle, and oh, so-and-so told me that if I want my baby to go home sooner, I should bottle feed. All of that kind of culture still exists completely in NICUs all over the country. So the tough answer to your question is that the culture in the unit must support the mother. And the culture in the unit isn't an overnight fix. So the culture can only change through education, but the culture has to change in order to support that mother. What you can do in the meantime, so I would say the real answer is that your whole entire unit needs to be educated in whatever one of those things you kind of choose as a method. They are all supportive of neurodevelopment. So whatever one you choose, help your unit be educated in that to change the culture of the unit. And then, but in the meantime, if you need help personally in this situation, try to find a little group of champions that will help support that mother. If it's, you know, few nurses, therapists, lactation, etc., that will support that mother and say, no, actually what we want is for you to have a great breastfeeding experience. Let's not worry about volume in the beginning. Let's just worry about the connection and milk transfer and just the experience of it, while your infant still gets most of their nutrition in their breast milk through an NG tube. But let's latch on, let's get this started, let's get this comfortable, positive experience, and try to support her in not giving up and taking that volume language out of the conversations, because the baby should still be getting most of their nutrition in the beginning will probably still be via tube. So just helping them, a few champions support that mother and taking that language out of the conversation.
So we have a question here. How do you thicken breast milk?
Yeah, that's a great question. Until recently, it was very hard to answer because rice cereal does not work to thicken breast milk. So that is not a solution for thickening breast milk. So the only product that I am aware of that can thicken breast milk is called Gel Mix. It's GELMIX, and it is made to thicken breast milk specifically and to thicken formula. So a couple things to keep in mind, however, it has been used in the UK for years and in the US more recently, but the recommendation is for 42 weeks post-menstrual age and 6 pounds. So I want to be very clear that there are very specific guidelines for the population in which that has been deemed safe. So again, that's 42 weeks post-menstrual age and 6 pounds, not or, but and 6 pounds. And that I was talking to Christy Sturdivant about this, and she actually said that the staff at a gel mix, they have physicians on staff. One of them is named Melissa Malone, and you can email them and they will, give you any advice or guidance, et cetera, GI physicians, et cetera, on staff. The nice thing about the gel mix is that it is a low caloric value, and it's tasteless, and it's soy-free. And if following the directions, it mixes very, very, very well. So it does mix to, I believe, to nectar and honey consistency, but keeping in mind that those things are, as we know, are fairly objective as far as measuring viscosity. So I do want to let you know that that's, keep that in mind. There are actually a couple talks at the Nant Conference this year about measuring viscosity and about thickening. So just if you're looking for more resources, but that website is gelmix.com. if you want to get more information on that.
Another question, do you have examples of protocols?
Yeah, so I think this is in reference to me saying during the talk that, pick a protocol of any sort that has, value, that has been deemed valuable and sound, but at least have one. And so some examples of that, of course, that I talked about during the talk, the infant-driven feeding model of practice definitely has a protocol. So if you, for example, went and took our online course by yourself at, infantdrivenfeeding.com, and then there's a link to that. Included when you're in the course itself, you can click on another button within the course and have access to the infant-driven feeding protocol, meaning that the entire course is really about the protocol, but as far as a written document to use in your NICU, we've provided the template for that so that you don't have to recreate the wheel. And it has all the components of infant-driven feeding in it, with a little room for customization, not of the infant-driven feeding scales, mind you, because those are copyrighted and should not be changed, but that some customization as far as length of time to protect breastfeeding, et cetera, based on your unit population. So that is one. Another one is protocol is the SOFI. So the quickest way to find out about that, in my opinion, is to just Google SOFI, capital, all caps, SOFFI, and you can find some resources and articles related to that protocol. And I'm using the word protocol. I think it's, a reference guide, actually, the article that will come up, and then you can find out more about that. And NAN has a guideline for infant-directed feeding, but again, more of a guideline about the practice of, I'd say, maybe more than a protocol. So those are a few resources that you can look to. And again, for the infant-driven feeding one, you can just go to infantdrivenfeeding.com, and then it's embedded in the course, because the protocol and the scales, again, are, to me, of much less value unless the whole unit is educated about what the practice actually is. And I believe that other authors would say the same thing. So,
what is your opinion on providing O2 for feeding them remotely? We know that babies have this latent effect on stress work, so would leaving it on for longer periods of time be better?
Okay, so I think what they're saying is if we give the infant, if we provide the infant oxygen only for feeding. So this is an infant that has been weaned off of oxygen, but we're putting it on just for oral feeds. Then should we leave it on longer after the feeding? So first is I would really think about why we're putting it on just for feeding. And again, that might be potentially appropriate, but I would try everything else first, meaning that is everybody on board with actually how to strategize the interventions that you need to be able to think through to prevent Brady's and DSATs, et cetera. So meaning that are we using the right flow rate nipple? Are we pacing the infant appropriately? Are they in a good position? Are we trying everything clinical first versus just seeing an infant that desats and turning their oxygen up? Because we can do a lot of clinical things first that might prevent those things, desats, before just turning the oxygen up, which is not benign. So that's what I'd say first, is try everything else. And then if you are putting it on just for feeds, I mean, you bring up a good question. I don't know that I have any evidence to suggest what is a good time to leave it on after the feeding. I know I don't have any evidence to say, this amount of time would be beneficial. However, I think it really depends on the infant. So if you know that infant and feeding is because of their comorbidity, not because we haven't fed them in the best supportive way possible, but because maybe they do have significant respiratory issues or something, if feeding is taxing for them in that way, and they do tend to have some after effects of that, even in the best of circumstances and in the best modeling and watching cues and disengaging, allowing the infant to disengage when they disengage. So if we're doing all of those things well, but that infant still has some, issues just with reserve from a respiratory standpoint, then maybe you do just leave the oxygen on the infant longer after the feeding. That would make sense. How long? I can't give you an answer for that. I mean, that's just going to depend on the infant and what your team decides makes sense for that baby.
How long does the breastfeeding experience need to be protected in a preterm infant?
This is $1 million question, I'll just say. So again, there is no one right answer to this. The right answer is really for as long as possible. However, it really depends on a lot of things: the unit culture, the support available for breastfeeding, how much the mother's there, how much they're able to engage in breastfeeding. So really the answer is it needs to be individualized. We try to recommend at least a few days of no bottles and only breastfeeding. However, it really depends on a lot of factors: the age of the infant, the availability of the mother, the support available to the mother to support her with breastfeeding, and all of the above. So we want to protect that as long as possible that makes sense for that particular infant and mother and family, and that particular infant's trajectory in the NICU in their case, really. So individualize that, but have a goal. So if your goal in your unit is, 72 hours or longer or whatever it is, just have a goal, and then as a team you can fluctuate from there based on the individual needs of the infant. But the goal really is dependent. I know you don't like this answer. The goal has to be dependent on your unit's population. Are you in a children's hospital NICU where they're in a different population in a birthing hospital, and all those things do matter. So really just think about what is the goal for your unit as far as protecting breastfeeding, knowing that longer is better, and make a reasonable attempt to start somewhere where everyone is comfortable, and then you can always improve it from there. So even if it's not your gold standard yet, start somewhere protecting it, and then keep increasing that time, especially for particular infants where the mother's very available and there's no reason not to, right? So start there, start with a goal, and move out from there.
So one of the responses is that everyone has probably heard, I don't need to feed the baby their way. I get the amount in the baby by feeding my own way, or another similar response. What's an easy one-line response to help with culture change for dealing with this type of a comment?
So a one-liner, that's tough. So if I had to give a one-line response to that, and it depends a lot on the attitude with which you deliver it, but really it isn't about my way, her way, this person's way. It's really about the evidence-based way, the best practice way to feed an infant, the safest way to feed an infant, the most pleasurable way. So I think we have to steer away from any language that is my way or your way, It's not about that. There's clear paths, no matter which method you choose, if we're talking a protocol or et cetera, they are all going to support feeding the infant in a neurodevelopmentally supportive way. And that includes certain criteria. And so that is the evidence-based way, the best practice way. So it's no longer us versus them or me versus you. It's about what we know to be true about feeding neonates. And if that other person isn't aware of that literature or that practice or anything, then that's a place where you can start to begin to educate someone. So I would say it's not my way. It's actually the way that has been proven to be best practice or evidence-based solution to feeding infants.
What are your views on nipple confusion?
So my views on nipple confusion are that I really wish we could get rid of that phrase. I believe that mostly it becomes a preference. I don't think the infant is confused. I think they have a preference. So meaning that when an infant imprints on one or the other, breast or bottle, so they're fed with one or the other solely for an extended period of time, they prefer typically that way. And we see this both ways, right? So an infant that is exclusively breastfed for X amount of time, and it depends on the infant and all these other parameters, is very difficult to then, at 2 months of age, feed by a bottle. I mean, very, very difficult. And the opposite is true. So an infant fed with a bottle only for X amount of time, which we don't know based on the infant, based on all kinds of factors, then may refuse the breast for the same reason. They have a preference. They've already established a preference. But I want to take the focus not only, it isn't just the nipple itself as much as the combination of that sensory experience because it could be the same whether it's just a rubber nipple on a bottle or a silicone nipple on a bottle or a breast or the nipple shield on a breast. So there's a lot of, look at it as a preference, and also that can be flow rate confusion. And I still don't like the word confusion, but it is an inconsistency. So the infant is expecting a certain amount, their sensory system, everything begins to expect a certain experience. And then if that is changed dramatically, it takes some adjustment. So if the flow rate from a breast, very different potentially from the flow rate of especially certain bottles. And so that is a different experience, something the infant may not prefer or may have to get used to. There may be an adjustment period, et cetera. So I'd think about trying to make the flow rate consistent between breast and bottle as much as we can. We can't replicate the breast, right? But as much as possible. And also thinking of it as what is the goal of that family? Because if the mother is exclusively breastfeeding for a period of time but eventually maybe dad's going to feed the baby a bottle somewhere down the road, or mom has to go back to work and she's going to have the baby at a babysitter, or anything where they will ever in their life get a bottle. If they wait until 2 and 3 months of age, I get lots of calls and emails of parents struggling with that situation. Now they won't take a bottle and I can't go back to work. And then the opposite is also true. So they've, especially when the baby's been fed by bottle in the hospital first, only without that protected time for breastfeeding, and now we're trying to initiate breastfeeding right before discharge, makes zero sense. So if that's still your practice, where right before discharge you're starting to put the baby to breast instead of first, that is old practice that needs to go away. We need to establish breastfeeding first, if that is the intention. So I think that mixing in some of both at some point that makes sense for that individual family, if that is the intention of ever doing both, is a great idea. If you're exclusively doing one or the other, then fine. But they will have a preference if they haven't been exposed to it.
When baby demonstrates a munching, chomping pattern with increased jaw excursion, can you give too much support at the jaw, as in pushing too hard? And then could the baby be pushing against your input the harder the input? Shouldn't this input be intermittent?
Okay. So if they're munching and have this increased jaw excursion, so you're saying if you're doing some kind of chin support, and could you potentially be making that worse? At least that's how I'm understanding your question. And so should that input be intermittent? And so I think what you have to look at is, what is the goal? And if the goal is that the infant has increased jaw excursion and they're unable to latch, the goal for me would be to just provide that chin support briefly in order to help the infant latch, and work on those skills and work on intraoral suction if that's the problem as well, because that's probably another problem that's associated with that. So, but I tend to use chin support very scarcely, and for a specific reason, get the infant, help the infant latch, breast or bottle, and then let go. For most of the time, if we can help the infant get latched and then help them with that intraoral suction, whether before we're going to breast or bottle or during, then we can, many times we can let go. We can not provide that chin support throughout the entire feeding. And if you do need to do it intermittently to help them maintain a latch, then fine. But I would go in with the mindset that this is not something you're going to sort of do in some sort of, I don't know, not harsh is the wrong word, but that you're going to continue to provide chin support. If the infant can't stay latched the entire time because of the jaw excursion, I would go back to more oral motor treatment first than trying to just fix it with chin support through an entire feeding. So I think using it for its intended purpose to help latch, or with a baby with micrognathia or retrognathia to help bring the jaw forward a little bit, great. But yeah, I wouldn't usually give chin support through an entire feeding unless it was for the baby who has those structural anomalies. If they have a preference for the rubber nipples over the silicone nipples and things, if that's the issue, then just try to transition them to the other bottle sooner. And if it's a breastfeeder with using a nipple shield, then that should be the first oral feeding at the breast, with or without nipple shield, depends on the situation, the baby, the mother, etc. But I would definitely try to imprint the breastfeeding first, so that you're not having that, again, that preference for the bottle or for the flow rate that comes from the bottle as compared to the breast. And if you allow parents to either bring bottles in, or you provide a bottle that's a commercial bottle that has a different nipple, I would just do that sooner or later, and especially with your breastfeeding babies. So bottle-fed babies, I think, tend to, if they're exclusively bottle-fed, they will typically, I would still try to expose them to whatever they're going to use eventually, perhaps in the NICU if that is congruent with your practice and your policies, etc. But they will tend to adapt more easily because the flow rate, everything else is going to be fairly similar. But if it's between breast and bottle, I would definitely start breastfeeding first. And then if you're introducing bottles, I would try to use a bottle that is similar in characteristics to the, as possible, as to the flow rate and sensory experience at the breast, which is tough, right? So if the baby is using a nipple shield, though, that is silicone, and I would use a bottle that has a silicone nipple, So whether that's Dr. Brown's, whether that you have another bottle that you like that has a silicone nipple. So having a similar experience from a sensory standpoint, especially if they're a breast and bottle feeder, is going to be important. And many NICUs in the country actually use Dr. Brown's for that reason, and I'm not saying that just because we're on this webinar, because not only because of the silicone nipple, which many bottles have, but because of its ability to adjust the flow rate to a more advantageous rate for a preterm infant, especially that is breastfeeding. The Dr. Brown's bottle requires you to have suction. So it will not work on compression alone, which is why it's a beautiful thing. So they have to have suction just like they do at the breast, or they can't get any milk out. And I don't know of any other particular commercial bottle that requires suction in that way at this point. So that is why I'm saying that. So even if you used a different one, those are the components that are important to mimic breastfeeding.
I have one more question, and I think this is a great question to end on. It says, when working with parents that seem to be having difficulty understanding a lot of information at one time, what is the best piece of information to give to that parent to take home first? I think we have enough time for one more question. When working with parents that seem to be having difficulty understanding a lot of information at one time, what is the best piece of information to give those parents to take home first?
That's a great question. So if you were going to tell them one thing, I guess, is your question, if you had one nugget to give them that they were going to carry forward?
That's what I understand.
Okay. I would say the most important thing is for them for the parent themselves, when they're in the NICU, the most important thing would be for the parent to feed their infant as much and as often as possible before they leave, because they are the most important part of their infant's feeding success. They are the most important aspect, because for too long, these feedings it hasn't been about a happy experience, a nurturing experience, an enjoyable experience. It has been about getting the volume in. And so if the infant and the family can understand that their role together is that this should be a nurturing, enjoyable, functional experience all the time, whatever method they're using. You know, even if they're being G-tube fed, this should be a pleasurable experience where they're held, where this is nurturing, it's fun. This is something the infant can psychologically count on as a nurturing, enjoyable experience. And it's not that we all don't have our issues. If you have a full-term baby and you've never breastfed before, or you've never just had a baby before, it can all be uncertain and have a little bit of, struggle, right? It's not like it's all rainbows and sunshine, but the feeding experience should be pleasurable for the infant and the parent. And so let that be your guide, whether you're in the NICU. It doesn't mean it's not a little bit scary for the parent, doesn't mean it's not new, but the infant should look like they're enjoying themselves. This should be a bonding experience. It should not be super stressful. We should be reducing the amount of stress associated with feeding by providing the infant the support we know they need, and the mother. And so whether they're in the NICU still, or whether they're out in the community and they're being told to do things that do not seem right in their gut about feeding, I think they need to understand that they can advocate from the point of, is this developmentally supportive of my infant? Because is it pleasurable? Is it nurturing? Does it make sense for lifelong feeding what I'm doing right now? So let that be their guide.
I want to thank you, Sue, so much for your presentation. It was very insightful and informative. We truly appreciate your time and, of course, your expertise in the field of infant feeding. Thank you all for joining us.
Thank you.